Our next speaker is Professor Sophia Zoungas, who you might have recognised on Stephen Nichols' thank you slide. She's none other than the head of Monash's School of Public Health and Preventative Medicine. She's a professor of diabetes, vascular health, and ageing. Professor Zoungas is an endocrinologist with clinical appointments at both Alfred Health and Monash Health. She leads large-scale clinical trials and health services research groups with a focus in the areas of diabetes, cardiovascular disease, and kidney disease and healthy aging. Professor Zoungas has more than 290 publications in peer-reviewed journals, including in the New England Journal of Medicine, Lancet Diabetes Endocrinology, Annals of Internal Medicine, and Nature Medicine. Please make welcome to the stage Professor Sophia Zoungas.
Thank you. Can you hear me? Thanks for that kind introduction. It's a real pleasure to be here. I'll start by acknowledging the traditional custodians of the lands on which we meet. I'm sure you've done an acknowledgement of country. It's the Wurundjeri people of the Kulin Nations, and pay my respects to elders past, present and emerging, and make the point, as there's an important dialogue discussion at the moment, the voice to Parliament, and we really, as clinician-scientists, need to be part of that conversation in a really productive way. So I hope you'll join me in being part of that conversation. So this is about networking and communication, and I want to share with you how I met Ingrid, who invited me to be part of this. And it's all about networking. And I was invited to attend a session hosted by Bellbury. Bellbury is one of the national human research and ethics committees. It's a private company that offer that service. And both Ingrid and I were invited to participate in a conversation, a discussion around the industry, the sector, clinical trial sector. And, you know, we were sitting next to each other at dinner, and Ingrid said, we were talking about our lives, and she said, you must come to the life of a scientist and present, you know, and be part of sharing your story with others. And so there you go, this is networking. We sat next to each other at dinner, hosted by another organisation. We had an interesting conversation, and here I am talking with all of you. So I'm going to give you a little bit of a sense. I'm taking a little bit of a different tack, and I'm leaving the imposter at the door because I'm following Steve Nichols, and that's a really hard act to follow. And I'm a first-generation migrant child, first into university in my family. My parents came from Greece, migrated to Australia in the 60s, and I was the first of their children to go to university. Never thought I'd be a doctor, did biology in year 12. I did very well, and at the time I was doing biology in year 12, Monash University and Alan Trounsden introduced and announced the first IVF successful baby. And I went, oh my God, wow, that's incredible. I want to be part of a career that allows me to think and do like that. So that was my inspiration and motivation. But my journey's been interesting, and I wanted to divide this sort of communication and networking discussion around being a clinician, being a clinical researcher or clinical trialist, being an educator and being an advocate, because I think that's the real opportunity for all of us as scientists. And this is more necessary than ever in the world, given the misinformation out there. And we've already heard about what, you know, nutraceuticals do, but there's even more terrible stuff out there. So this is me, and this is where my home is currently. It's a School of Public Health and Preventive, Monash. We're at the Alfred campus. We're in the Alfred Hospital precinct, but we're on 553 St Kilda Road, and we're in the building that's shared with the American consulate. So if there's a bomb scare, we're all rushing out, but we haven't had too many of those in the last few years since COVID, but clearly we were expecting more given what was happening in the US. What was really interesting is, so I started as a clinician. I'm an endocrinologist by training, and it was at that time that before I finished my advanced training, that I decided that I'd do a PhD, given what inspired me to go into medicine. And so I did my PhD in clinical trials, and at that time, at the end of my PhD, decided to become a full-time senior medical staff at Monash Medical Centre. Out then it was called the Burbs, because everyone was studying at Prince Henry's and Queen Vic and RMH and St Vincent's in the city, and we got sent out to the Burbs. You know, it was almost like being sent out to the colonies. It was a great place to be, MMC, because it was real, you know, greenfield. That, you know, and we were all trying to work out how we were going to work together. And clearly there was a great unmet need. So I really got interested in a specialty where I felt there was interesting pathophysiology, interesting physiology, interesting medical research, and that's what sent me down the path of doing endocrinology, to the very chagrin of my mentor, who was a nephrologist. And in fact, my PhD was in end-stage kidney disease in dialysis patients. So at the 12th hour, I converted to a different stream of advanced training. He was really upset with me, but he's forgiven me now, and he remains a really close colleague. But at that time, after doing my PhD, which I thought was reasonably successful, and I only discovered that it was reasonably successful because, in fact, you know, I did a clinical trial, a definitive clinical trial, and I couldn't get it published. You know, I went to New England, and New England said no, and then I went to the Lancet, and they said no. And then I happened to go to present my findings at the national meeting, and I went to the social event at that national meeting, like we all do. You know, it was the Congress. They have a social event. So I decided to go to the social event as a young sort of, you know, PhD student. And so, as it so happens, at the dinner table again, it's amazing who you network with and meet at dinner. Sitting next to me was this lovely lady who was an American lady, and she happened to be the wife of the keynote speaker that had been invited. Now, the keynote speaker was the editor of the major journal Circulation. And not that I knew this at the time, but his wife, who was sitting next to me, was saying, oh, you know, how are you and what's going on in your life? And we, you know, had a conversation, and she said to me, what's happening in your life? And I said, well, look, I've just had a baby, and I'm trying to get my final paper of my thesis published. And in fact, I was the first PhD student to do a thesis by publication. The first cohort, in fact, that had that opportunity to do that. But I can't submit my thesis until I get this paper published. And I've had this problem because I've just had my paper rejected by this big journal called Circulation. She said, what? And that's my husband, she said. Give me a minute. I'm just going to speak with him and get advice as to why he rejected your paper. Would you have ever known that that could ever happen? So this is networking at its best. So she turned to her husband, berated him on him stalling my career and not allowing me to go back to my young baby because I had to, you know, keep submitting this paper. And in fact, he gave me really good advice. He took me aside. He told me to submit the paper to Journal of American College of Cardiology, and within a month it was published. You know, great impact, great outcomes. So another sort of example of networking. So I won't go through my whole career, but I'm currently head of public health and preventive medicine, and that's a bit unusual, I think, for clinicians, because people think public health is someone else's, you know, someone else does that. But in fact, public health physicians and other clinicians that go to public health, some of us come to public health early and some of us come through our advanced clinical training. And I think they're both equally valuable ways to get to the proposition and to bring something different to what we need to do. Because as we saw with the pandemic, a huge amount of work needing to be done. More recently, I've been appointed as the academic director of a clinical trial centre at Monash that brings together our collective capabilities. But really, my whole career has been focused on diabetes and cardiovascular disease, and more recently, healthy ageing, given population ageing and how important it is to tackle the problems for our society. I've been an investigator of many large-scale clinical trials, but I also work in clinical quality and do cohort studies. And part of my journey in networking and to share with you has been around, being part of professional societies, being part of patient advocacy groups. I've had the privilege to be the president of the Australian Diabetes Society, a board director of Diabetes Australia, and the clinical director of the National Association of Diabetes Centres. And they were all opportunities that came to me during my journey through networking, through meeting people, through going to scientific exchange, but also volunteering time. We're volunteering time here today. It's really important to say yes to opportunities. And it may not be immediately evident why you're saying yes or who you might meet, but if you think you're going to learn something, put yourself out there, because to me that was an incredibly important part of what I was learning, participating, volunteering, but I was really learning along the way, and it's been a great joy and pleasure. All right, so I've got some highlights I want to share with you, because this is about communication, and indeed, as a clinician, it was Sir William Osler many, many years ago, we call him the father of medicine, that taught us about the art of medicine. And he said the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Often the best part of your work will have nothing to do with the potions and powders, but with the exercise of an influence of the strong upon the weak, of the righteous upon the wicked, of the wise upon the foolish. Osler was a pathologist, an educator, a bibliophile, a historian, author, and renowned practical joker. And so this is part of what we all bring, and I hope you bring, to being a clinician. And indeed, I was thinking about this and thinking, well, what does the evidence tell us about being a good physician? Because we're talking about the life of a clinician-scientist. And so I did find a publication, Evidence-Based Medicine, that's me. So the BMC many, many years ago, and there were some others, researchers were interested in assessing the preferred attributes of a good physician, and they examined domains of patient autonomy, professional expertise and humanism. And surprisingly, the attribute that was the highest priority for patients was actually for the physician to respect the patient's autonomy. And clearly, that tells us something about the perspective of patients of what a good physician is. So something we need to learn about how we influence and how we communicate in day-to-day clinical care, but also more broadly in our lives. All right, this was my vision, and this is the girl, remember her? I tell myself this is to inspire me and keep me going, because sometimes they're really hard. This has been a really hard week. In clinical service, I'm actually on service at the heart hospital. We had some really difficult patients, but also we've had some really difficult situations with projects. And so I remind myself, she's still there inside you waiting, let's go get her. And so this is to remind look for the inspiration. And for me, my vision in being a clinician-scientist is being understanding key evidence gaps, research that's embedded in local communities. I think that's really important. Promoting equity, promoting evidence-based care, and looking at how we translate what we do into policy and practice. Right, so I'm a clinical trialist. And we're talking about communication. We should never forget scientific communication is the number one thing that we need to get right. And so I had the opportunity after my PhD and during my postdoc to be part of a major international trial. And so I was able to go to major scientific meetings and present the findings of that trial. And that trial was huge. It had, 213 centres from over 20 countries around the world. Real opportunity. Again, in terms of networking, I met the original PI of the trial at a function, and he asked me, well, do you want to come and do a postdoc? And there you go. You're off and your career changes. In being part of that proposition, I had the opportunity to think about some of the important questions. And we always thought that normalising glucose would improve outcomes, and what sort of glucose targets should we set? So we were interested in this time around were the targets different from the near normal range, and in fact this is looking at mean HbA1c as the outcome and looking at this non-linear relationship and describing a threshold effect that in fact if you took it to near normal you in fact potentially could be producing no greater benefit but also introducing harm. And we were interested in trying to understand how that occurred and whether the benefits would be additive with a management of other risk factors. And I'm showing you this because it's a way we try to effectively communicate our science, where we have a diagram that indicates the effect of modifying one risk factor, but also another, in this case blood pressure, and showing that the benefits are additive. What about thinking about plausible other ways of communicating your science? And this is just to show you that we actually showed an adverse relationship with hypoglycemia and cardiovascular disease for the first time, but also had to think about the pathophysiology of this relationship. And here you can see a figure communicating science in a diagram, but getting a large number of complex concepts together so they make sense. And that's part of our responsibility in sharing science, not only with our peers, but with the lay community. All right, this is where I am now, and I've come forward and done quite a few trials, but Steve's talked about definitive data and lipids and the importance of the major trials. And what we've done in the work that we've done collectively is think about preventative care and our ageing community. And you may say, well, statins reduce cardiovascular disease, and why do we need another big trial? But in this proposition, we've brought together a team that are really interested in outcomes that are broader than just the traditional cardiovascular events. And we're thinking about statins' role through its pleiotropic effects, potentially being of benefit of prolonging healthy life expectancy. So not just prolonging life expectancy, but keeping people well in the community, independent, out of hospital care for as long as possible. And so this proposition's now been going for about 5 years, and we've recruited over 9,000 participants. We have 3,000 GPs working with us. We've got 4 sub-studies, 50 dedicated staff, and over 1,400 biobank samples. Again, an example of having conversations, bringing teams together, and really asking the big, hard questions and taking responsibility for identifying and reporting on the definitive answers. All right. Next part is of being an educator and a mentor, and you've heard already from Steve how important that is. Teams are really important, and in fact, Dr. Ingrid Hopper is a really talented clinical pharmacologist at the Alfred and general physician. And I've had the pleasure of being her mentor and working with her, and she's really saying here how important it is. A PhD is really a great journey, and you know, Ingrid's done a variety of different things, but again, your ability to meet people and look for supervisors and mentors that are not necessarily within your clinical domain or the area of interest, but may go broader than that. All right, and I've worked with a lot of students and fellows, and it just shows you that the journey's been different for a lot of them. But I wanted to make the point here that all of these PhD students that I've had the opportunity to supervise are not doctors. They come from nursing backgrounds, they come from orthotics, they come from physiotherapy. They come from overseas, they've come from a range of different backgrounds. So I think that's really important to make sure that you're mentoring or seeking mentors, not necessarily just the mentor that's within your area of clinical interest. All right, just to make the point, teamwork's important. And I'm a dance mum, my daughter was a ballet dancer, and this just reminds me how in medicine and in communication, how important it is that we work together. The team approach always leads to a better outcome. It's also our responsibility in thinking about working as teams to think about how we communicate our research vision. I've shared with you my research vision, but I think you need to ask yourselves this. Are you asking the right question? Do you know your audience? Are you ensuring you've got optimal collaboration? Is your communication well written and presented? Consider, have you thought of the elevator pitch or the plain language statement to explain complex concepts? And finally, have you sought peer and consumer involvement and review? And have you considered the ethical considerations of the way your science is developing? And more broadly than that, I think we need to consider research waste. And I've been interested in this for a little while where, it was actually during the time of COVID where there was a paper that was published that showed that of the funding that had been awarded during the COVID pandemic, in fact, very little of it had actually delivered true clinical outcomes or definitive answers. And so I think we've got a responsibility to make sure that the research questions we're asking and communicating about are patient-centred and have value for money, feasible and transparent. All right, finally, advocate. Big picture, we have all a role in this room to play in recognising what the problems are, being aware of continuum of health risks, supporting and driving and influencing the public health agenda, and I hope you'll be part of that. And social enterprise is so, so important. How we engage with community and policymakers will lead to much better outcomes and much more influence and effect. And I've had the privilege to be involved in some of that work. This was being part of an international study group where we were really concerned about the way hypoglycemia was being reported around the world, and we were able to produce a position statement. And in fact, these criteria are now standard reporting criteria to every regulatory body around the world, FDA, EMEA, TGA. So really proud of the fact that we came together as a scientific community and were able to communicate a clear and transparent way of reporting an important adverse outcome. Some other work that I've been involved with for a very long time with the diabetes community in Australia is really about a national diabetes strategy. And this has been launched a few times, but more recently has been updated for the period of 2023 to 2027. And this is really big picture stuff around, what is the government investing in? What is the government implementing? Where is our health budget going? What can we do at a micro and a macro level, jurisdictional, federal level? What's our individual responsibility? And finally, I think in terms of communicating and acknowledging, and Steve's shown his acknowledgement slide, this is one way. We usually acknowledge our partners, our research institution, our major funders, those people that have supported us, and I've had the privilege to be working with a lot of different groups. But clearly we need to acknowledge the people that are the closest to us, that inspire us. This is my family, and we should not forget that in communicating, we should remember those that inspire us on a day-to-day basis, keep us honest. And I'm going to leave you with my final words. I hope I haven't gone over time, but clearly reach high for stars lie hidden in your soul. Dream deep, for every dream precedes the goal. Clearly words that inspire me, and I hope it's inspired you today. Thank you.
Thank you so much, Professor Zoungas, for an excellent talk. I will open the floor to any questions now. Just in the middle.
Yep. Great talk. Thank you so much for that. My name is Moran. I'm a MD PhD student at the Baker Institute, and coincidentally, I'm very interested in healthy aging research as well and considering endocrinology in the future. Wondering from your perspective, how much overlap do you see between healthy aging research and being able to practice as an endocrinologist, and how do you integrate them together?
I see only opportunities, not barriers. We traditionally come through a pathway of clinical care or clinical training, advanced training, but clearly there's so many synergies. The reason why I sort of moved into healthy ageing was because, we were treating so many people with chronic conditions, and trying to understand how we can prevent those chronic conditions was really important to me. So in the clinic, I could have at an individual level, affect change at the patient level, but what I was increasingly frustrated about was how could I prevent those patients coming to need my care? And as Steve said, we thought cardiovascular disease was going to be cured, and his heart hospital is full. It's similar for diabetes, right? We've got 1.5 million Australians affected by diabetes, and probably another 500,000 who have pre-diabetes. And I started thinking, what could I do beyond that would help at a population level? And so healthy ageing, thinking about it as a public health priority was important to me. And then extending that to because I had the skills. We had clinical skills and I had research skills. And so it was developing the ideas and the vision around where my research was going to go. So asking those big questions for me wasn't scary. It was actually, it almost became a responsibility that if I could, why wasn't I? And so moving into healthy ageing was really about thinking, how could I prevent disease? How could I prevent the longer years of life lived with disability and more years lived as healthy as possible? And part of my motivation was really, my parents were getting older. They've recently passed away, but clearly, I felt that, imperative that I had to move into that space and make a difference if I could. So, short answer, long answer. Your heart's got to take you where your head and your heart have to take you where you want to go. And I don't think your clinical specialty limits you. And working in a multidisciplinary, interdisciplinary way is the future. And so I would, if that's where your heart is, you can still do your clinical training, but, where your research lies can be quite broad.
Thank you.
Thank you for the talk, Professor Zoungas. I've got a question. As a community, we're becoming increasingly aware of the role that the commercial determinants of health play, in particular when it comes to obesity and diabetes. To what extent do you believe that, I suppose, scientific research can actually have an impact when it comes to the commercial determinants of health and driving the public health agenda in that regard?
I think it's got a huge role, and I think it's something that we've forgotten about. I know Sandro is doing his talk next. I don't know if he's here yet, but I'm sure Sandro is going to talk about it. And I think as clinicians we forget about that aspect because we're treating the condition, not necessarily the whole person. And I went into medicine, and we were taught back then 20, 30 years ago that holistic care was important, and yet we're going back to that biomedical model. So incredibly important. If we look at obesity, if we don't tackle some of the commercial determinants of health, it's going to get worse. If we just see it as a biomedical disease. So we see it in diabetes all the time, where, the social determinants of health are the risk factors that are actually, increasingly leading to worse outcomes. So I think we've got a responsibility. I don't like separating them now. I think you've got to see the whole picture. And if you can understand what those are, you can affect change or be part of the conversation around how to affect change.
Join me in a round of applause for Professor Sophia Zoungas.